Hello guys, very good afternoon. Myself, Dr. K. Roja, and I am the Faculty of Physiology, and I'm here to discuss the physiology questions that have been asked in the INICET November session 2022. Okay, so we'll have a quick recall of the various questions and the few concepts which are related to the questions. Okay, yes, let us move on to the question. The first question. It says the curve B in the following image depicts. So these are the two graphs which were given in the question, and the options were like methemoglobin, fetal hemoglobin, myoglobin, and carboxyhemoglobin. Okay. So first of all, what is this graph? We all know that it is the oxygen hemoglobin dissociation curve. Okay. Now, out of these two, A and B, which one is the oxygen hemoglobin dissociation curve? It is the curve A. Now, he's asking us what B is. Okay, so now let us have a look at this oxygen hemoglobin dissociation curve only. What is the normal shape of the curve? It is sigmoidal in shape, and the sigmoid shape is because of the phenomenon of cooperative binding. Okay. Now, this cooperative binding is seen whenever the hemoglobin, the adult hemoglobin, is binding with the oxygen. It means as one molecule of oxygen binds with hemoglobin, its affinity for binding with the other molecules increases. That is, totally it will bind with 4 molecules of oxygen. Okay, so that is about the sigmoidal shape and its significance. Okay, now there is a shift of the curve which can happen. Okay, it could be either a left shift or a right shift. Okay, now why will there should be a shift of the curve? Ideally, this curve is the showing us the relation between the PO2 and the oxygen saturation. So whenever these conditions change, whenever the PO2 changes, there could be a change in the saturation, the binding of hemoglobin with oxygen, and hence the saturation. Hence, there will be either a right or a left shift. Okay, so first we will see what are the causes for left shift and what does that signify. So what does a shift of the hemoglobin curve, oxygen hemoglobin curve to the left mean? It means the affinity is increased. Means at lesser partial pressure only, the hemoglobin can bind with, oxygen hemoglobin binding is seen. Okay, it means the increased affinity. Or right matlab, affinity is reduced. Now, what are the various causes for increase or decrease of this affinity? If you look at the causes for the left shift, the first one is the alkalosis. Okay, it means pH is increased. The second is decreased carbon dioxide, decreased temperature, and then we have the decreased 2,3 dpg or 2,3 dpg. Okay, what does 2,3 dpg do? It will bind with the hemoglobin, the beta chains of the hemoglobin, and it will displace the oxygen. Okay, means if there is more 2,3 dpg, more oxygen will be displaced. So oxygen will be released. And if 2,3 dpg is less, affinity will be increased. Okay, and these are the various conditions. And apart from this, there are other reasons like fetal hemoglobin and then carboxyhemoglobin, where you can see a left shift of the curve. Okay, now a shift of this oxygen hemoglobin dissociation curve to the left because of decrease in the CO2, that is nothing but your Haldane effect. And similarly, if you look at the causes for the right shift, again the opposite conditions, like for right shift it is acidosis or decreased pH. Okay, increased carbon dioxide, right? Increased temperature, and then increased 2,3 dpg. These are the various causes for a right or a left shift. Okay, now if I am saying that there is increased affinity, means it will lead to loading of oxygen and less release of oxygen from the hemoglobin. And the right shift matlab where the affinity is reduced, means it will cause unloading of oxygen Okay. And increased oxygen release. So this is seen at the tissues. This is at the level of the lungs, not the left or the right shift, but right. So this is what the shift of the curve to the left and the right mean. Now, what will be the reason for this carboxyhemoglobin causing the shift of the curve to the left or increased affinity? Okay. So what does this do? This carboxyhemoglobin, it will, this carbon monoxide itself has got a greater affinity for oxygen, hemoglobin. Okay, since it has got a greater affinity to hemoglobin than oxygen, the carbon monoxide binds with hemoglobin. Okay, that is one reason. And if you look at the, what do we say, the curves for both carboxyhemoglobin and the normal hemoglobin, the P50 for this carbon monoxide is 0.5 millimeters of mercury. It means even when the partial pressure of carbon monoxide is so less, it can bind with, the hemoglobin is already 50% saturated with it. And the rest of the 50% is left over for oxygen or something like that. Okay. So it will cause a shift of the curve to the left. And what about this fetal hemoglobin? Fetal hemoglobin has got the alpha and gamma chains instead of alpha and beta chains. Okay. And we have this 2,3-DPG, which is actually binding with the beta chains. And since hemoglobin F has got only gamma and no beta, the 2,3-DPG binding will not be seen with the hemoglobin. And if there is no 2,3-DPG binding, it means there is increased oxygen affinity for this hemoglobin F. And that is the reason how the hemoglobin F or the fetal hemoglobin is able to bind with oxygen from the maternal circulation. Okay. So that is how the fetal hemoglobin is. And then, okay, that is about the fetal hemoglobin. Then we have another graph, that is the myoglobin. This is another component which is present in the skeletal muscle. Okay, which is iron containing again. It's an iron containing protein and iron is there, so it can bind with one molecule of oxygen, unlike the normal hemoglobin, which can bind with 4 molecules. Now, what is this myoglobin? It can bind with one molecule only. And if you look at the dissociation curve of this myoglobin, it is a rectangular hyperbola rather than a sigmoidal curve. Okay, the shape is rectangular hyperbola. That is about the myoglobin. And if you look at this myoglobin curve and the normal hemoglobin wala curve, you can see that, say for example, the PO2 is somewhere around 10, say suppose for example. Okay. Where is the saturation greater, with myoglobin or with normal hemoglobin? Myoglobin. It means myoglobin has got greater affinity for oxygen than the normal hemoglobin. Okay. And if you look at this, even at a PO2 of 5 millimeters of mercury, myoglobin is already 60% saturated. Whereas normal hemoglobin at 5 millimeters of mercury, it is not even 10% saturated, normal hemoglobin. Whereas myoglobin is 60% saturated. So what is the significance of this? Is it acts as a reservoir for oxygen in a skeletal muscle. So it is helpful in conditions of exercise to release oxygen. Okay. So that is about the myoglobin. Now in this picture, so this curve B is a curve which is for the myoglobin. Okay. So the answer is myoglobin. Okay. So that is about the first question. Now we will move on to the second question. Okay. we have the next question that is regarding the macular densa. So the question was, macula densa is located at the junction of thick ascending limb of loop of Henle and the distal convoluted tubule, convoluted tubule and the thick ascending limb junction, and distal convoluted tubule, descending loop of Henle and the ascending limb of loop of Henle, the junction of the descending and the ascending limbs of loop of Henle. Okay. So the question is, macula densa is located at option A, thick ascending limb and the DCT junction. Option B, proximal convoluted tubule and the thick ascending limb junction. Option C is descending limb and the ascending limb of loop of Henle junction. Okay. So these are the options. Now, what is this macula densa now? So you all know that macula densa is a component of the juxtaglomerular apparatus. Right. Now, this is an important component which is present in the kidneys. And now, this juxtaglomerular apparatus has got three important subunits. Okay. So, one is the JG cells or the juxtaglomerular cells or granular cells. And the second thing is the macula densa cells, and then there is this mesangial cells. Okay, mesangial or the lassus cells. These are the three important constituents of the juxtaglomerular apparatus. Now, what is the function of these granular or the juxtaglomerular cells? These are the cells which secrete renin. Okay. Now, where are these present? That is one thing. And coming to this macula densa cells, these are the cells which act as the sensors for the sodium and the chloride composition in the tubular fluid. And then we have the mesangial or the lassus cells, which are nothing but the contractile elements. Okay, so these are the three components. Now, where are these cells, various cells situated? Okay, so yes, this is the juxtaglomerular apparatus. Okay, consisting of the macula densa cells, granular cells, and the mesangial cells. Okay, now if you look at this particular diagram, these granular cells. Now, where are these granular cells present? These are mainly present in the afferent arteriole. Okay, these are present near the afferent arteriole, and then the macula densa cells. So these will start secreting renin, and this is under the influence of the sympathetic innervation. Okay, or the sympathetic nerve stimulation will be regulating the, as you can see over here, regulating the release of this renin from the granular cells. Then these are the macula densa cells, which is given in the question. So the macula densa cells are nothing but the specialized epithelial cells which are present in the, or which are nothing but the lining of the thick ascending limb of loop of Henle. Okay. Now, where are they present in the thick ascending limb of loop of Henle? These are present near the junction of the thick ascending limb of loop of Henle and the distal convoluted tubule of the nephron. Okay. So these are the macula densa cells, which are nothing but the sensors, or which will sense the sodium and the chloride composition in the fluid. So this is about the macula densa. So let us go back to the question. So macula densa is located at, the answer is thick ascending limb of loop of Henle and the distal convoluted tubule junction. Okay. So now the function of these cells or this juxtaglomerular apparatus is mainly in the maintenance of the tubuloglomerular feedback. So that is the function of the JG apparatus. Okay? Yes. The next question is, the principle of the following instrument is. So this was the instrument which was given, and I could get only 2 options related to this question. So the options are acid hematin and alkaline hematin. So first of all, what is this instrument? If you remember, you might have handled this instrument in your first year physiology practical. So this is the instrument which is used in the estimation of hemoglobin, right? And the name of this instrument is Sally's hemoglobinometer. Okay, so Sally's hemoglobinometer. Now, what is the principle of, or the working principle of this instrument? So it is, what we do is, in this particular experiment, we'll not go into the depth of it. N/10 HCl will be made to react with the given sample of blood, which reacts with the hemoglobin present in the RBCs, okay, and results in the formation of acid hematin. Okay, so the concentration, now you take up the acid and add blood to it, let it for some time, and you will see a colored fluid inside the tube. Okay, now the color of that fluid will depend on the concentration of the hemoglobin. More is the hemoglobin, more is the acid hematin form. Okay, so now this will be diluted with the distilled water, and you will estimate the, what you will do is you will try to compare the color of this fluid with the color of the comparator rods, which gives you an estimation of the hemoglobin. So the principle which is used in this particular experiment, that is with the Sally's hemoglobinometer, is the formation of acid hematin. So the answer is A, acid hematin. Okay, let us move to the next question. Yeah, the next question is, violent one-sided movement is seen in the lesion of caudate nucleus, globus pallidus, subthalamic nucleus. Okay, so what do you understand by this term violent one-sided movement? Okay, one-sided, hemi, and violent involuntary movements. Okay, now this is nothing but the condition of hemibalismus, which is seen in the lesions of the basal ganglia. Now, basal ganglia has got a lot of other structures, okay, like the subthalamic nucleus, the caudate nucleus, the putamen, okay. So these are the various structures of the basal ganglia. Now, hemibalismus is caused due to the lesions of the subthalamic nucleus. Okay, and since it is saying hemibalismus, means it is occurring only on one side, right? So which sided lesion will cause this? Suppose if a patient is having the movements on the right side, these involuntary movements on the right side, okay, so it is caused due to a lesion of the subthalamic nucleus on the left side. Okay, so the lesion occurs due to the the symptoms occur due to the lesion of the contralateral subthalamic nucleus, right? Now we will look at the other involuntary movements which are seen in the basal ganglia. Okay, the other one is the balismus, okay, or balisms, which means again the same involuntary flailing. Okay, these are the adjectives which are used. Okay. Violent, intense movements. Okay. That is about the balisms. And then there is another involuntary movement that is nothing but acidosis, which is nothing but continuous, slow, breathing movements. Okay, now this acidosis is seen in the lesion of striatum. Okay, and then we have this chorea. Okay, now what is chorea? This is again the same rapid, involuntary, and dancing like movements. And this is seen in the lesion of the caudate nucleus. Okay, so these are the various involuntary movements which are seen in the lesions of the basal ganglia. So the answer for this is the violent one-sided movement, that is hemibalismus, is the lesion of the subthalamic nucleus. Okay, let us move on to the next question. Right, cells present in the molecular layer of the cerebellum. Okay, so what are the cells what are the options given? One is the Purkinje cell, and then the granule cell, Golgi cell, and the stellate cell. Okay, so before going on to the cells which are present in this molecular layer, what are the various types of cells and the layers? Okay, so if you look at the cells, first of all, we'll have a look at the layers of the cerebellum. So what are the various layers of the cerebellum? The outer molecular layer, and then we have the Purkinje cell layer, and then we have the granular cell layer. Okay, now what are the various cells which are present in this layers? Okay, now Purkinje cell layer, the name itself says that it is having the Purkinje cell, and in the molecular layer we have the basket cell and the stellate cell. Okay, and then we have the granular layer which has the granule cell, right, and the Golgi cell. Okay, now these are the 5 cell types which are present in the cerebellum. So out of this, the question asks this molecular layer mein kaun sa cell? What cell is present in the molecular layer of the cerebellum? Okay, so out of this, which one are the ones? It is a basket cell and the stellate cell. So what is in the options given below? It is the stellate cell. Okay, now if you look at, these are the layers and the cells, right? Now if you try to look at the inputs to the cerebellum, okay, so there are majorly 2 inputs, or inputs from the 2 types of fibers, right? One is the climbing fibers and the other is the mossy fibers. Okay, now where are these climbing fibers coming from? They are coming from the inferior olivary nucleus, right? And they will stimulate the Purkinje cell. They have the excitatory connections or the synapse with the Purkinje cell. And then there are these mossy fibers, okay, which are nothing but the connections of the spinocerebellar, reticulocerebellar, okay, and then the vestibulocerebellar and the cuneo-cerebellar tracts. Okay, so these are the 2 types of input fibers and the output. These are the input fibers, these are the cells, and there is a output. And the major output from the cerebellum is through the Purkinje cell. Okay. And what kind of output it is? It is the inhibitory output. Okay. So this is about the cerebellum and the cells of the cerebellum. Okay. So yes, we will move on to the, so the answer for this question is the cell which is present in the molecular layer of the cerebellum. It is the stellate cell. If the answer was, option was basket cell, you can opt for basket cell. Okay. So yeah. Then we have the next question, that is the hypothalamo-hypophyseal tract releases. Okay. So where did you hear this hypothalamo-hypophyseal tract? Hypothalamo-hypophyseal means it's basically the connection between the hypothalamus and the hypophysis. Okay. So what are the options? Anterior pituitary hormones and posterior pituitary hormones. I could get only these two options. Okay. So what is this? We all know that the pituitary has got two subdivisions. Basically three, but we talk mainly about two, anterior and the posterior pituitary. Okay. And the hormones which are released by both these anterior and the posterior pituitary hormones, posterior pituitary, are under the control of the hypothalamus, various nuclei of the hypothalamus or the cells of the hypothalamus. Okay, so the question given over here is hypothalamo-hypophyseal tract releases. So how is that connection established between the hypothalamus and the pituitary is important, right? Now, this hypothalamo-hypophyseal tract is mainly the connection between the hypothalamus and the posterior pituitary. Okay. Now, which is also known as neurohypophysis. Okay. So there are two types of neurons in the hypothalamus. That is the, two types of nuclei. That is the supraoptic nucleus and the paraventricular nucleus. Okay. Which synthesize various hormones. We'll see what it is. Okay, now after synthesis, those are stored in the form of vesicles and are transported along with this axons. That is nothing but the hypothalamo-hypophyseal axis or the tract. And here they are released into the circulation. Okay, and what are those two hormones which are released in this manner? One is the antidiuretic hormone or vasopressin, and the other hormone is the oxytocin. Okay, so which nucleus releases which hormone? The supraoptic nucleus will be releasing the ADH and paraventricular nucleus releases the oxytocin. Okay, so the hypothalamo-hypophyseal tract will release the posterior pituitary hormones. Then what about this anterior pituitary? Okay, so for the anterior pituitary hormones, there are what is known as the releasing substances or hormones which are synthesized in the hypothalamus and they are sent into the anterior pituitary via the blood circulation. Okay. And in the anterior pituitary, they will stimulate various types of cells which synthesize various hormones like the thyroid stimulating hormone, LH, FSH. Okay. Various types of hormones are released from the anterior pituitary. Okay. So the question is hypothalamo-hypophyseal tract releases which hormones? The tract will release the posterior pituitary hormones. The next question is regarding the ventricular action potential. I couldn't get the options for this, but probably there was a question regarding the phases of the ventricular action potential in the morning session. Okay, so now we all know that this is the action potential of the myocardium or the ventricular muscle. Okay, so when you look at this action potential, there are various phases. Okay, So the initial phase, if you see, the rapid depolarization phase. Okay. The depolarization is due to the influx of sodium, large influx of the sodium ions. Before depolarization, what is the resting membrane potential of the ventricular myocardium? It is minus 90 millivolts. Okay. And then depolarization is mainly due to the influx of the sodium ions. Okay. And then this is a phase 0. Then there is a, once the membrane potential reaches to around plus 20 to plus 30 millivolts, there will be inactivation of the sodium channels. So the sodium channels closes, there is no more influx, and that will activate the opening, or that will start the opening of the potassium channels. Okay. Then the phase, this is phase 0. Then we have the phase 1, okay, which is nothing but the initial repolarization phase, which is due to the potassium. And if the potassium channels are opened, the general tendency is the potassium efflux, because there is more amounts of potassium in the intracellular fluid. Okay. And then there is, if you can see over here, it is actually something like this. Okay. So this phase, the phase 2, is the plateau phase. Okay. Plateau means the resting membrane potential is relatively stable. Okay. So why is that so? So when will the resting membrane potential be maintained constant? It is when there is no net diffusion of ions across the membrane. Okay. So here, what are the ions which are present? The potassium, and also here there will be opening of calcium channels. Okay. At this particular phase. So the plateau phase is because the calcium influx. Okay. There will be influx of calcium, which is almost equivalent to the efflux of potassium. So there is a positive charge which is moving out and a positive charge which is coming inside. So the net diffusion is relatively constant. Okay. Or we can say that there is no proper net diffusion. Hence, the membrane potential will be maintained constant. Okay. That is a plateau phase. Then there is the next phase, which is phase 3, which is a phase of rapid repolarization. As you can see, the membrane potential is falling rapidly. Okay. And as we all know, this is due to the potassium efflux. Okay. And then we have the phase 4, which is nothing but the phase of the resting state, which is maintained by the, again, universal sodium potassium pump. Okay. So these are the various phases. Now I don't know what the question was like regarding what probably the question might be like, what could be the ionic flux during a particular phase? That could be a question related to physiology. So this is about the ventricular action potential and the phases. Okay. Let us move on to the next question. The next question is, water reabsorption from PCT in the absence of ADH is. Okay. So what is this water reabsorption from the nephron? You need to know that. Okay. So the options are isotonic, hypertonic, and hypotonic. Okay. Yes. So if you look at the water reabsorption in the nephron, okay, it doesn't occur in a single segment of the nephron. It happens in various segments or the multiple segments of the nephron, which are responsible for water reabsorption. So the first segment is the PCT. Okay. So now at the level of this PCT, what will happen? It is known as obligatory water reabsorption. Obligatory matlab it will happen. Okay, so what is this obligatory water reabsorption? Here, mainly in the PCT, the water reabsorption is secondary to the solute transport or the solute reabsorption. Okay, first the solutes will be reabsorbed, which will create an osmotic gradient, as a result of which water will also enter into the plasma or the tubular interstitium. Okay, so the water reabsorption in the PCT is always secondary to the solute transport. Hence, both solutes and water are being carried away. So, the fluid over here will be isotonic. The composition of the fluid which is exiting from the PCT will be isotonic. And the fluid which is reabsorbed at the level of the PCT is also isotonic, because both solutes and the solvent is getting reabsorbed. So the reabsorption is isotonic. Okay. Now this isotonic fluid is entering into the descending limb of loop of Henle. Okay. Now this descending limb of loop of Henle, what is the peculiarity? It is permeable to water, but not permeable to solutes. So what will happen? All the solutes tend to remain in the tubular lumen itself. Okay. Hence, the fluid will become hypertonic. Okay, which is leaving the distal limb of loop of Henle. Now this hypertonic fluid will turn and then enter into the ascending limb of loop of Henle. Okay, now the ascending limb of loop of Henle, okay, this is not permeable to water, but permeable to solutes. Okay, so if it is not permeable to water and permeable to solutes, what will happen? All the solutes will be reabsorbed into the plasma and water will be retained inside the tubular lumen. So the fluid which is coming out of the ascending limb of loop of Henle, or which is entering into the DCT, is hypotonic, because water is retained in the tubular lumen. Now this hypotonic fluid, it will then enter into the DCT and the collecting duct. Okay. Now, in the DCT and the collecting duct, what will happen? Now, here comes the role of our antidiuretic hormone. Okay. So, here two things. Okay. At the level of the DCT, if ADH is present, water is reabsorbed. Okay, if water is reabsorbed, the tubular fluid will be hypertonic. Okay, and if the ADH is absent, water reabsorption will not be there and the tubular fluid will become hypotonic and increased volume. Right? Now, where do you see this condition? More amount of urine. This is now, next is nothing but the urine. Okay. So, where do you see this condition of greater volumes of hypotonic urine getting excreted? The condition is your diabetes insipidus. Okay, so this is a condition where you see this increased volumes of urine, which is hypotonic, and that is when there is ADH absent. Okay, so what the question is, what the reabsorption from the PCT in the absence of ADH is, whether it is isotonic or hypertonic or hypotonic. Normally, when it is not given as PCT. That is only the question is water reabsorption in the absence of ADH is. I mean, what is the type of urine that is excreted out? In the absence of ADH, it will be hypotonic. Okay. This is a normal phenomenon. And the question over here is asking about the PCT. Okay. As mentioned earlier, PCT water reabsorption is dependent purely on the solute reabsorption. And hence we are saying it as obligatory water reabsorption, which is around 70% of water reabsorption. Okay. And that is independent of ADH. Okay. And hence, whether or not ADH is present, I mean, if ADH is present or absent, it is secondary. Water reabsorption will be isotonic in the PCT. Okay. Now, this reabsorption of water in the DCT and the collecting ducts, it is known as facultative or facilitatory water reabsorption. Okay. So, one was the obligatory and the other is facultative water reabsorption. So, these are the two types of reabsorptions, and the answer for the question from the PCT in the absence of ADH is isotonic. Okay. Yes, we'll move on to the next question. Least arteriovenous oxygen difference is seen in. Okay. The options are skin, kidney, heart, and the liver. Okay. So, least difference of oxygen between artery and vein means the oxygen extraction is high or low. The oxygen extraction, if it is less, means the oxygen which is taken up by the tissues is less. There will be increased amount of oxygen in the vein also. So, the arteriovenous difference will be reduced. Now, out of the given options, which tissue has the low oxygen extraction? Okay, or the less oxygen utilization. Okay, so we will have a look at this table. Right? So, as you can see in this table, there are two things mentioned. One is the blood flow, the oxygen consumption, and the arteriovenous oxygen difference. Okay. Now, as you can see in by these values, the arteriovenous oxygen difference is least in the kidneys. Okay. And the greatest in the brain. It means brain is extracting more of oxygen, whereas kidneys are extracting less oxygen. Okay, here. Then, if you look at the blood flow, so there are certain points which you need to remember regarding these. These are basically memory things which you need to remember. So, the first thing is greater blood flow per minute is by the is towards the liver and the kidneys. Okay. Greater portion or greater proportion of the cardiac output will be reaching the liver, followed by the kidney. Okay. Then, right, greatest to the liver. And if you look at this is the overall blood supply. If you look at the blood supply per 100 grams of tissue, the greatest is flow per 100 gram per minute per tissue. That is more at the kidneys. Okay. It means as kidneys are receiving a greater blood flow, that is 420 ml per 100 gram of tissue per minute. There is more flow of blood to the kidneys. Okay. And since the blood flow is so huge that it doesn't have to work hard to extract more oxygen. Hence, what will happen? Since the flow is greater, oxygen extraction is less. And if the oxygen extraction is less, it means the arteriovenous oxygen difference is also less. So that is what your question is about. Less arteriovenous oxygen difference is seen in kidney. Okay. And more in brain. Greater extraction, greater metabolism. Okay. So these are the two things which you need to remember. And if you look at the oxygen consumption also, this is having a greater oxygen consumption per 100 gram of tissue. Right? Since blood flow is more, consumption is also increased. But if you look at the overall oxygen consumption in terms of ml per minute, overall as a tissue as a whole, which one is consuming more oxygen is liver, followed by skeletal muscle. See, the things are different. Flow is different, extraction is different, consumption is different. Okay, so these are certain important things which you need to remember regarding the blood flows, oxygen consumption. Okay. Then we have the next question, which was the match the following. Okay. So yes, the options given are Kupffer cells, parietal cells, Clara cells, and the dust cells. It's a straightforward direct question. We all know that the Kupffer cells are the ones which are present in the liver. The parietal cells are the ones which are lining the, the lining of the stomach or the gastric epithelium, which are secreting HCl. Then we have the Clara cells and the dust cells. Now, Clara cells are the ones which are present in the bronchiole, which are nothing but the secretory cells. Okay? Non-ciliated secretory cells which are lining the bronchiole, whereas dust cells are the ones which are lining the lungs, also known as the alveolar macrophages. Okay, so these are the various types of cells and the tissues where these are present. Okay, so this is a straight question. Then we will move on to the next one. Insulin dependence is seen in. Okay. The options given are pancreas, adipose tissue, neutrophils, and I know the other option. Okay. So what are the insulin dependent tissues? Now it means the tissues for which the glucose uptake is dependent on insulin. Okay. So there are insulin dependent tissues and insulin independent tissues as well. Okay, so what are the various insulin dependent tissues that are present in the body? One is the liver, the skeletal muscle, right? Adipose tissue. Okay, so these are the insulin sensitive or the insulin dependent tissues. It means the glucose reabsorption is dependent on the insulin. Okay, and what are the what do we say, the proteins which are responsible for this? It is nothing but the glucose transporters. Okay, whereas there are certain insulin independent tissues, okay, where the glucose uptake is independent of insulin. Tell me one important one common tissue. That is nothing but your kidney, where the glucose reabsorption is happening through what is known as SGLTs, sodium glucose co-transporters. Here, there is no need of insulin for reabsorption of glucose. Okay. Yes. So kidneys is one structure, and then there is this RBC, GIT, brain. Okay. All these structures made is insulin independent. Okay. So these are the various structures, and the answer is insulin dependence is seen in adipose tissue. Okay. Yes, let us move on to the next question. Yeah, cerebral perfusion pressure. The formula for cerebral perfusion pressure is asked. Okay, so what is the cerebral perfusion pressure basically? Now, if this is the cerebral circulation or the cerebral blood vessels, okay, here they are, and then there is the CSF, and then comes the brain tissue. Okay, so cerebral perfusion pressure is nothing but the, it completely depends on the pressures which are present in the cerebral circulation. If there is increased or decreased pressure, it will definitely alter the perfusion or the supply to the brain. Okay, so how is this cerebral perfusion pressure calculated? It is calculated by the formula mean arterial pressure minus the intracranial pressure. This is the formula for calculating the cerebral perfusion pressure. Okay, suppose there is increased intracranial pressure due to some lesion. Okay, what will happen to the cerebral perfusion pressure? It will reduce. If the cerebral perfusion pressure falls, what will happen to the proper blood supply? Blood supply to the brain. It will be similar to the hypoxic condition at the brain. Okay, or if the mean arterial pressure is reduced somehow, then also the cerebral perfusion pressure will fall. And when can the mean arterial pressure be reduced? Whenever there is decreased cardiac output, decreased blood pressure, mean arterial pressure will also fall. It means there is reduced blood supply to the, the perfusion pressure will fall, so that the blood supply to the brain also, brain tissue also is reduced. Okay, so that's about the cerebral perfusion pressure. Yeah, and then the next question is true about the neurogenic shock. Okay, so what is this neurogenic shock? What are the various reasons for the shock? What are the options given? First, we'll see hypotension and bradycardia, hypertension and bradycardia, hypertension and tachycardia, hypotension and tachycardia. Okay, so coming to this neurogenic shock, the name itself says it is due to some neural condition. So what is that? It is the most common cause being the spinal cord injury or the transection of the spinal cord, or a condition like GB syndrome, Guillain-Barré syndrome. In all these conditions, there will be this, you see this condition. Okay, so what will happen in these conditions where the spinal cord injury is seen? There will be the disruption of the autonomic nervous system. Okay, now we know that autonomic nervous system has sympathetic and parasympathetic limbs. So in this particular condition, what will happen? The sympathetic stimulation will be reduced and overactivity of the parasympathetic system is seen. Okay. Now, as a result of these two effects, what will be seen at the level of the heart? Now, we know that heart has got a great amount of autonomic innervation. Okay. So, it has got both sympathetic and parasympathetic innervation. Now, at the level of the heart and at the level of the vasculature, both the things are of importance to us. Okay. So, at the level of the heart, if the sympathetic stimulation is reduced, what will happen? This is reduced. So, the heart rate, okay, the contractility, okay, will be reduced. And if both heart rate and contractility are reduced, what will happen to the cardiac output? Reduced. What will happen to the blood pressure? Reduced. So you will see hypotension. And then coming to the vasculature, what are the effects on the vasculature? And also, yeah, heart rate. Heart rate is also reduced. Hypotension is seen. And also bradycardia. And then coming to the vasculature, since the sympathetic innervation is disrupted, there will be vasodilation. Okay. Now, what are the consequences of vasodilation? Vasodilation will lead to decreased vascular resistance. Okay. That will also reduce the blood pressure. Okay, so overall in the neurogenic shock, you see hypotension and bradycardia, which is due to a decreased sympathetic activity. Now, what treatment can be given in this neurogenic shock? Okay, so since the sympathetic innervation is reduced, you will try to give the sympathomimetic drugs to increase the sympathetic stimulation to the heart and the vasculature. Okay, so this is regarding the neurogenic shock. Yeah. Then we have the next question, that is regarding the stagnant hypoxia. Okay, so what is this stagnant hypoxia? Okay, so there are basically 4 types of hypoxia. Excuse me. So there are basically various types of hypoxia. So what does hypoxia mean generally? It is decreased oxygen supply to the tissue or decreased oxygen utilization at the level of the tissue. Now, what are the options which are given? Now, the answer, the option could be either true or a false one. I don't know the exact question. Even these options I have framed. This was a question regarding the stagnant hypoxia. Okay, these could be the probable options. And we will see out of these which one is correct and which one is incorrect. Okay, so there are various types of hypoxia like anemic hypoxia, hypoxic hypoxia. Okay, and then we have the stagnant hypoxia, and then comes the histotoxic hypoxia. These are the various types. Now the question is regarding the stagnant hypoxia. So what does the name stagnant imply? Stasis. Okay, it means the hypoxia which is caused due to the hypoperfusion, decreased perfusion, and there is other name because of this phenomenon that is given to the stagnant hypoxia. It is nothing but the ischemic shock or ischemic hypoxia. Okay, so let us not go into it. So basically it is because of the hypoperfusion. Now, when can this hypoperfusion be seen? Whenever there is circulatory failure. Okay, or cardiogenic shock or sluggish blood flow. All these things, what do? They will reduce the blood supply to the tissue. Okay, but if you look at the alveoli, artery, hemoglobin concentration, hemoglobin saturation, okay, the alveolar PO2, the arterial PO2, hemoglobin concentration, all these are normal. Okay, problem, where is the problem? The problem is in the hypoperfusion. The flow is so slow, flow is sluggish, reduced blood flow. Because of that, what will happen? There will be, since the flow is less, the tissues needs to meet their demands. Okay, so what will they do? They will try to extract more oxygen. Oxygen extraction will be increasing. Okay, and hence, what will happen to the arterial venous oxygen difference? The arteriovenous oxygen difference will be increased. Why? Because arterial oxygen content is normal. Because hemoglobin, saturation, PO2, everything is normal. This is normal. Problem, where is the problem? The problem is in the oxygen extraction. There is increased extraction because the tissues are getting so less blood that they tend to meet their needs by removing more oxygen from the blood. Hence, the venous oxygen will be reduced. So, if this is normal and this is reduced, what will happen to the arterial venous oxygen difference? It will be increased. And since the amount of reduced hemoglobin or the deoxygenated hemoglobin in the blood is increased, there will be cyanosis. So these are the various features of the stagnant hypoxia. So we'll have a look at these options. Arterial and alveolar PO2 normal. Yes, it is correct. Oxygen saturation normal. Yes, correct, because hemoglobin is also normal. Cyanosis present. Yes, correct. AV oxygen difference, arteriovenous oxygen difference is decreased. No, it is the arteriovenous oxygen difference which is actually increasing. Okay, so the question might be the false statement, or it could be the other way around also. They could have given all the false statements and given one true statement and asked you to choose. Okay, so this is a concept regarding the stagnant hypoxia. Okay, yes. Now, yeah, we will move on to the next question, which is regarding the anion gap. Now, this is the one important question which can be asked in multiple ways. And I think anion, the options were metabolic, alkalosis, metabolic, acidosis, respiratory, alkalosis, and respiratory acidosis. Okay. Now, we all know that anionic gap, again, it's a simple question. Anionic gap is seen in the metabolic acidosis. So what is this anion gap basically? According to the principle of electroneutrality, okay, the concentration of the cations must be equal to that of the anions in the body. Okay, but all of them are not measurable. And there will be a difference which is created due to those non-measurable components. Okay, and that is nothing but your anion gap. So this anion gap is nothing but the concentration of the cations minus the concentration of the anions. It is arising due to presence of such ions which are not measurable. And what are such things which are not measurable? The proteins, inorganic phosphate, okay, and then the sulfates. So these are certain components which are responsible for this anion gap. Okay, now what are the major cations that we know? Sodium. Potassium is often negligible. The extracellular concentrations. And the anions are, major ones are chloride and bicarbonate. Okay, so what is a normal sodium concentration? It is 135 to 145 milliequivalents per liter. So let us take it as 145 minus. Chloride is 105. And the normal bicarbonate concentration is 24. So it is 145 minus 129, which is coming to around, 16. Okay, 16 milliequivalents per liter. Okay, so this is the normal anion gap. So this is a single value. Now it is sodium is not exactly 145, chloride is not exactly 105. It can change a little. Okay, so normal anion gap is 10 to 18 milliequivalents per liter. Okay, now why do we need to know this anion gap? Yes, it is seen in metabolic acidosis, but again, there are conditions where the anion gap is increased or decreased. It is normal. Okay, so where do you see this increased anion gap? Okay, which is known as high anion gap metabolic acidosis. Okay, so where do you see that? Now, this is seen mainly in conditions like diabetic ketoacidosis, okay, lactic acidosis, right? And certain poisonings, what do we say? Yeah, certain poisonings like salicylates, okay, methanol poisoning, ethylene glycol poisoning or ethanol, okay, and drugs like INH, uremia, all these things are causing the high anion gap metabolic acidosis. And there are certain conditions which causes normal anionic gap metabolic acidosis. And what are those conditions? They are mainly diarrhea. Okay. And any GI conditions like ureterosigmoidostomy. So what is happening in all these conditions? There is loss of bicarbonate. Okay. Here. Diarrhea or ureterosigmoidostomy. Loss of bicarbonate. If bicarbonate instead of becoming 24, it is coming to say, for example, 14. What will happen to the anion gap? It should increase. But what will happen over here is there will be a compensatory increase in the chloride level. So this is associated with hyperchloremia. Okay. And this bicarbonate is reduced, but chloride is increased. Hence, the total value will be maintained constant. Hence, the anion gap is normal. But if you look at the conditions where the anion gap is increased, it means there is loss of bicarbonate without much compensatory increase in the chloride levels. But there is a compensatory increase in the other anions like your inorganic phosphates, proteins, sulfates, etc., which might be the reason. Now, these are the components which are responsible for anionic gap. Now, if anionic gap is increased, means the concentration of these things are increasing in the body. So, high anionic gap metabolic acidosis is associated with either a normal or a reduced chloride concentration. There will not be any hyperchloremia in the high anionic gap metabolic acidosis. So, but I don't know whether the question is just regarding the anionic gap or the question was regarding high or normal anionic gap. So, based on the question, the option will be varying. But if it is only regarding anionic gap, it is seen in metabolic acidosis. Or the other ways, the question can be like, maybe they'll give you some conditions and they'll give you high anionic gap is seen in. Okay. Maybe they'll give you diabetic ketoacidosis, salicylate poisoning, INH, and then diarrhea. So the option will be all except matlab diarrhea, because in diarrhea it is normal anionic gap metabolic acidosis. Okay. So this is about the anionic gap. And yes, this concludes most of the questions which have been asked in physiology in INICET November session. So I hope I have covered most of the things. Okay. So yes, thank you.